Hi guys, so another day, another question today. We're gonna dive into it. So today's question is actually by Ben. All right, so Ben is asking something a bit different from everyone: adult onset myopia. So he's asking about a patient that he had in the early 30s, Asian male with progressing myopia. So prescription on the right eye minus 7.25 with a 150 sil, axis 180, and the left eye minus 6 with a 250 sil. Now, so he seems to be increasing by minus 0.50 in 7 months. Now, I would say that that's quite a bit, especially for adult onset myopia. We usually wouldn't really expect much changes anymore, but this shows us that it is still possible to progress even if you're at a much older age, right? So, I have him updated some updated spectacles, but what would you guys do? All right, Ben. Firstly, thank you for the question. Very valid question for this community because so far what we've been talking about, okay, has been primarily been about around kids. But yes, adults also do still progress when it comes to myopia. And something that we have to really consider, okay, when we look at adult onset myopia is why is the vision changing? All right. So in this case, minus 0.50 in 7 months. Yes, it could be just normal myopic changes. That's why they're getting this change. But another thing to also consider is also maybe things like systemic conditions. So, for instance, diabetes. Diabetes can actually cause a myopic shift in the prescription in a short span of time. So, that's one thing that we definitely do not want to forget about. A few other things also is actually to check the corneal topography, because with the topography, if we can take the topo itself, we can know if there's any corneal changes, and if there is any corneal changes that's happening, then it might be a corneal disease that we're looking at. For instance, like keratoconus. No doubt, keratoconus usually onset is much younger, but if there are some like changes in the cornea, maybe a bit later on in life, that could also cause a myopic change. Now, the other thing that's also worth considering is to measure axial length if you do have access to it. So a biometer is great, if you do have it in practice, because we just want to make sure that when we monitor it, that for these adults, their myopia, their eye is not growing too much in a way. Okay, so we just want to make sure that that's the case, really. All right, so those are a few things that probably just before we really dive into it, we want to do. Now, let's talk about some of the risk factors. Like, what are the risk factors that can really affect adult onset myopia? And there's actually a couple. But sorry, before we dive into that, when we talk about like pathological myopia or vision change and all these kind of things, there has been a paper which shows that an axial length greater than 26 millimeters definitely will cause a myopic things like myopic vision impairment. So let's have a look at it. So there's this paper over here. Okay, yeah. So as we can see in this particular paper that we have, where it talks about like the axial length with risk of uncorrectable vision impairment in a European population. Okay, all right. So over here we see that yes, the age group is generally a bit older because that's where usually most of these patients, how old they're going to be. And we can see here that it did mention that for axial length between 24 to less than 26 even, visual impairment is about 3.8% for the participants aged 75, okay, or above in a way, all right? And of course, look at this, 90% for anyone with an axial length of above 30 millimeters or greater. So this is how shows us how axial length is definitely a risk factor in terms of how much changes that can happen. But also, of course, they did look at the prescription, showing that, of course, anything with like a -6 diopter, that's definitely in the high myopia range. We just want to be a bit more aware of it. But let's look at what they categorize as visual impairment. Okay, so visual impairment and blindness, defined by the according to the World Health Organization, is a criteria of visual acuity less than zero point 0.3. So this is based on a logma. So if you're talking about like on the Snellen chart, that's 612. So anything like 612 or worse, anything worse than 612. So if your patient is seeing like 615 or 618, 620, now that's where you know that their vision, that is considered visual impairment. All right, so we just want to be aware of that. Okay, Now, we've talked about the topography already, yeah, which, if we measure the topography, we know that if there are any risk of any other eye condition. Okay, so let's have a look here at another paper which talk about what are the risk factors. Okay, so the risk factors here that we can see from this particular study by Mark Ballymore. Okay, so one of the big researchers in the field of myopia management, definitely. So this paper was, let's have a look at when it was done. I don't think it was too long ago, but again, I might be wrong. Okay, yeah. So this was done in 2006. So it's quite a while already, but still pretty relevant. So a few things that they were having a look at here. Okay, so near task, high accommodative or ACA ratio, and high lack of accommodation. So these three factors, if you do measure it in your myopic patients who are a bit older, they are still progressing. I wouldn't be surprised if these values are actually much higher in those patients. So it's actually worthwhile measuring it so that we know where the myopic patients are really sitting at. Okay. Now, when it comes to what works, there's actually very limited study that is done on this. Okay. Yeah. So because the limited study is because most of the progression that we see is usually in kids. So when kids are progressing, that's where we want to really stop things, and that's where most of the research is focused on. But with adults, there's definitely less work on it. But there's two particular papers that's actually worth looking into. So let's have a look and dive into the first one. So this is one of the papers, which is by none other than Kate and Paul Gifford. All right, so our very own Australians of optometrists and clinical scientists who are in the field of myopia. Yeah, so this study actually looked at a couple of things, not just the axial length or the myopic changes, but if we have a look here, so they even measure things like binocular amplitude, accommodative lag, and divergence and all this stuff. But the one that I really want to focus on is this. Okay, so this is actually like a 12-month study of ortho K, and yes, the sample size is a bit small. Okay, so adults age 18 to 29, there's 8 of them. Okay, and when we have a look here, it says axial length did not significantly change in either children, all right, significant value p equal to 0.025, or adults p equal to 0.72. Okay, so this is good. This shows that there's no significant changes, at least we know, with ortho K. So it shows that it's good to know that there is a method that works. Yes, small sample size, but it's something that we can learn from. All right, so this study was actually done in 2020, a bit more, I mean, published in 2020. Yeah, so it's pretty recent. There's a study that's a bit older. This one was in 2016, and which it was published. Yes, that's right, February 2016 when it was published. This has an even smaller sample size. So we're talking about literally just 3 people. Okay, so it's university students doing corneal refractive therapy, also known as ortho K. All right, so 1 male and 2 female. All right, so it's good to see that in the conclusion here that the patients report the possibility of, sorry, okay, if you look at the results, so treatment was successful, all right, with uncorrected VA of 2020 or 66 or better monocularly. So during the 3-year follow-up period, right, this is what we see. The subjects did not experience progression in refractive error. Okay, so let's highlight this. Not experience progression in refractive error, nor in their axial length. How good is that? Okay, so that is literally as good as it gets. Okay, so it's good to see, although yes, it's a small sample size, so we just want to be a bit more like aware of it. But this shows us that ortho K does work. Okay, so yeah, so to answer your question, Ben, yes, there is probably a way that we can help to slow it down even more, which is with ortho K. One thing to take note, yes, parents, sorry, not parents, patients, because they're a bit older now, so they can make the decisions on themselves. Some of them might not be as keen on ortho K because of most of the time is because of the pricing, but also maybe some of them just prefer wearing glasses. Okay, so they might not really be as open to the idea of contact lenses. But if you deem that they are actually progressing, and it's not because of systemic issues like diabetes, or it's not because of any kind of like changes to the cornea, then we can be pretty confident that it is a myopic progression. Most of the time is because they have like prolonged knee work. Okay. And it's worth measuring these other two things also. So things like ACA ratio and lack of accommodation. Yeah, because we know that those things do affect it. But if we know that it's truly myopic progression and we don't want our patients to just keep progressing over time, it's worth talking to them about ortho K. Usually, I find that with most working adults who are like in their late 20s, early 30s, especially those in their 40s, I would say, they rarely would cringe at the price of ortho K because they're working and they usually can afford it. Yeah, it's usually like when you talk about ortho K to parents for their kids. That is a bit of a different story. Okay. Yeah. So this is where it might be a bit easier for yourself, Ben, to actually be able um, to convince your parents, convince your patients to get into this. So that will be my answer. And I will leave all the references in the comments in this particular post for you so that you can have a look at all of it, right? So thanks for your question, Ben. And yeah, keep asking this question, keep it coming, and I'll be sure to help you out with it. And I'm sure everyone else in this community here will be able to do so too. All right. So till next time.